Can you all see the screen?
Yes, sir.
Right. Okay. Cerebrovascular disease is a very important topic because it's a very common problem in medical practice, and you must know acute management of stroke as well as the follow-up. And the other important aspect is that the prevention of stroke is very important because it causes significant disability and mortality. Now, at the end of this lecture, you should be able to diagnose a patient with stroke and TIA based on clinical features and localize the site of the lesion in relation to the lobe and the involved vascular territory. You have to plan emergency investigations and acute and long-term management. You should be able to describe the emergency management of ischemic and hemorrhagic stroke. Describe the evaluation and investigation in a young patient with a stroke. And you also should have an idea of the facilities available for rehabilitation of patients with stroke in this country and the other supports they can obtain, and take appropriate action on primary and secondary prevention of stroke. Stroke is defined as a rapidly developing focal or global loss of cerebral function with symptoms lasting more than 24 hours or leading to death, which is due to a vascular cause. Now, this definition has to be changed now because if we go by this definition, we have to wait till for 24 hours until we diagnose this patient. But we know that there are therapies available which are very effective within first few hours of the stroke. So this definition is not 100% accurate for management purposes currently. Why do we want to study stroke? It is for one of the reason is that, as I said, it's the third cause of mortality in Sri Lanka, and mortality is about 65.4% for 65.4 per 100,000 population per person years, and incidence is not clearly investigated in Sri Lanka, but the prevalence is about 0.1 per thousand among the people above 18 years old. And disability adjusted life years, if you take, is about 1073. Now this varies from different country to country, and the prevalence, as you know, does not only depend on the incidence, it depends on the mortality also. So prevalence will not give a real idea of the problem. Most of you would know that we discussed in the previous lecture also that the clinical features of stroke is mainly the onset is very sudden, and any neurological deficit which is of sudden onset except uh, seizure should be considered as a stroke and plan the management appropriately and take appropriate actions. And disability caused by the stroke depends on the side of the brain affected and the exact site of the brain affected, which in turn depends on the artery affected. For example, if you have a lesion in the left occipital lobe, you'll get a right macular sparing homonymous semianopia. And that area is supplied by the posterior cerebral artery. So you can, from the disability, you can predict the lobe involved to a great extent, and the artery affected. For example, if you have a left middle cerebral artery infarct in a right-handed person, you know it will be global aphasia. The patient will have probably global aphasia. And the other way, if somebody presents just with global aphasia, you know that it must be from a branch of left middle cerebral artery. Now we cannot discuss all the areas of the brain and all the arteries which will cause different types of clinical patterns. But for an example, you should be able to mention the abnormal physical signs or clinical features that you would find in different parts of the brain, and the arteries which supplies those areas. For example, anterocerebral in the prefrontal area will be supplied by anterocerebral artery, which causes behavioral changes, disorientation, gaze palsies, and urinary incontinence, especially if it is bilateral. Now, frontal motor strips, on the other hand, is supplied by, although it's in the frontal lobe, it's supplied by the middle cerebral artery, and you get a face, arm, leg weakness. And if it's on the dominant hemisphere, you will get aphasia. Brain stem is supplied by basal artery and its branches, but this branching of basal artery is very complex. So rather than having full battery artery occlusion, the common problem occurs with involvement of penetrating arteries, so that you get different types of symptoms. Now, if you can summarize them, if the cranial nerve symptoms are low motor neuron cranial nerve symptoms are on one side, and the pyramidal signs are on the opposite side of the body, then they are very likely to be a brainstem lesion. For example, in so-called Weber syndrome, there is third nerve palsy on the ipsilateral side of the lesion and contralateral hemiparesis. In a pontine lesion, you get a lower motor neuron facial nerve palsy with upper motor neuron signs on the opposite side of the body. Whereas if it's a cortical or internal capsular lesion, you get upper motor neuron facial nerve palsy and the pyramidal weakness on the opposite side. So that in a patient with internal capsular lesion, facial nerve palsy, arm and leg weakness are on the same side. Whereas in a pontine lesion, Lower motor neuron facial will be on the side of the lesion, and the pyramidal signs would be on the opposite side. Posterior inferior cerebellar artery, which causes the lateral medullary syndrome, is another common area that is questioned in the exam papers. You get hiccup and checkerboard like sensory loss, where there is face of the same side and the opposite limbs will have a sensory impairment. They can have dysphagia and cerebral signs as well. And of course, Horner syndrome. Parietal lobe, as most of you would know, is supplied by a branch of middle cerebral artery, and it causes contralateral hemianesthesia. And in the dominant parietal lobe lesion, you get left-right disorientation, acalculia, agraphia, and finger agnosia. Non-dominant parietal lesions will cause geographical disorientation. If you go to the pathology of stroke, there are two main pathologies. One is a cerebral infarct, which are all called as ischemic strokes. And then the rest is intracerebral hemorrhages, which can be due to many reasons. Now, before you diagnose a patient with stroke, you must remember that there are stroke mimics. This is especially important because we now give thrombolytic therapy for patients suspected to have a stroke. And at very early stages, CT scan may not show any changes. So, one of the common uh, problem is psychogenic weakness. So, it is very difficult to diagnose whether the weakness is psychogenic or not. However, the physical signs may not fit into any anatomical distribution, and the examination finding may be inconsistent from person to person who examine the patient. So, however, we cannot take a risk, and we do most of the patients, especially young patients, we manage them uh, as a stroke in the sense that we do CT scans and look for other causes, unless we are very sure that it's psychogenic. Seizures sometimes can cause weakness, especially at its post-ictal stage. So that has to be considered, and if a weakness has followed the seizure, we should not give thrombolytic therapy if unless the imaging studies show very acute cerebral infarct. Hypoglycemia is another thing which can present sometimes with focal neurological signs of sudden onset. So if the patient has very low serum glucose, you must always exclude the possibility and treat and exclude the possibility of hypoglycemia. Sometimes migrainous aura can present with a hemiplegia. Let's call a hemiplegic migraine. The clues would be there is a preceding aura of visual uh, spectrum, and headache would be uh, generally unilateral, and it has characteristic features of phonophobia, photophobia, following which or with which you get uh, hemiparesis. That's called hemiplegic migraine. And sometimes hypertensive encephalopathy can present with focal weakness, especially cortical blindness, that is due to the cerebral edema of the occipital lobe, which causes cortical blindness, which is transient and get better if the blood pressure uh, is quickly controlled. Now, this has to be differentiated with a patient with severe hypertension getting a stroke, either hemorrhage, commonly a hemorrhage, or sometimes an infarct. It is very important to look for risk factors when the patient has a history of stroke. Now, sometimes we may not spend time on taking detailed histories because the patient need early treatment, which you will understand when we discuss the section of the management. The so-called common vascular risk factors like hypertension, diabetes mellitus, and dyslipidemia are the commonest in most of the patients. And young patients nowadays, you have to look for drug abuse, and smoking alcohol is very important. Look for, especially chronic alcoholism can lead to strokes, but smoking is a known risk factor. Migraine, as I said, can mimic strokes as well as sometimes it can cause uh, minor strokes. In females, use of oral contraceptive pills is a known risk factor. Obesity, sleep apnea are risk factors, so is the family history. But these are commonly in little middle-aged and elderly people. But in young patients, you have to think of other causes like vascular disease, like SLE, other vascular disease, and sometimes hematological conditions like polycythemia, and for that matter, relative polycythemia in elderly due to dehydration also can cause strokes. Carotid and vertebral dissection should be inquired in patients where there is a sudden neck extension for some reason. Thrombophilic conditions are now commonly encountered. The most common entity is antiphospholipid syndrome, but there are many other uncommon conditions. Uh, in the history, there are other things that we should inquire about. Especially in acute ill patients, we have to quickly take the history for the contraindications for thrombolysis, and we have to assess their disability and handicap and social issues. However, when the patient comes within 3 hours with an acute stroke, we don't time spending time on taking these details, but we proceed to the management. When you are examining a patient with a stroke, of course, weight and the BMI is important. Patients should be looked for polycythemia, evidence of vascularity crash, joint swelling or lymph nodes in young people, evidence of xanthochromia and tendon xanthomas and xanthelisma in little middle-aged and elderly patients. Obviously, neurological examination is very important. Our aim is to find out the disability and any significant affection of the swallowing, speech, and so forth, which are important for the management, and to find out the NHS score. Um, Cardiovascular system examination is the next important system in a patient with a stroke. You have to check blood pressure and then the pulse rate, especially with regularity. And when you are presenting the case also, you must keep uh, about the regularity of the pulse rate or irregularity with an emphasis so that the examiner would know that you have looked for them rather than just telling it. Jugular venous pressure is important just to see whether there is any evidence of a heart failure. Cardiomegaly is important and the murmurs would be important. And the another aspect which also belongs to the cardiovascular system would be looking for bruise over the carotid arteries. And if there are bruise, and in young patients who have no other uh, cause for stroke, you may have to examine the peripheral pulses. Respiratory system should be examined, especially if the patient's consciousness is impaired or swallowing is impaired, and you must look for evidence of aspiration pneumonia. And abdomen should be examined for liver, spleen, and sometimes kidneys, depending on the case. In the emergency situation in the ETU, you must check the capillary blood sugar and, if possible, random blood sugar immediately, and rush the patient after immediate assessment. If there is no, if the airway, breathing, and circulation is intact, most of them should be intact unless the patient is unconscious, you have to rush the patient for the CT brain after taking the quick history. ECG, full blood count, should be arranged urgently, and we do PTINR, serum and creatinine. They are important, especially for thrombolytic therapy. However, we don't wait till the results comes to start thrombolytic therapy. You all following? Are you all following?
Yes, sir.
Yes, sir.
Right. Okay. Now we can clearly identify two groups of patients with strokes. That is, we know that middle-aged and elderly people and the young people. In elderly people, unless there is a physical sign which is pointing to some other diagnosis, some basic investigation would suffice, like fasting blood sugar, lipid profile, full blood count, ECG, chest X-ray, and echocardiography, serum creatinine, and we do carotid duplex, especially in the carotid territory uh, cerebral infarcts, because if there is obstruction, there is a way of preventing it. Other investigations, if relevant, depending on the clinical picture. Complication of strokes. It is very important to know that the patients with strokes die more of their complications start than the stroke itself. Some people say approximately 50% die of other medical complications. Uh, the common one would be aspiration pneumonia, uh, respiratory failure and distress due to aspiration pneumonia. Sometimes they can get pulmonary embolism, sepsis. They also can get myocardial infarction or heart failure due to their pre-existing illness. Acute kidney injury, hyponatremia, gastrointestinal bleeding, that is due to stress ulcers. Impaired nutrition after prolonged ill health, urinary tract infection, and post-stroke depression. And so, whenever patient with a stroke is becoming unusually drowsy, you must always think of other causes. For example, if the patient has a very small infarct in the left corona radius or left internal capsule, we say, can this patient be unconscious? Is it likely? Very small infarcts without midline shifts. And if the brainstem is not involved, it is very unlikely that the patient is unconscious due to a very small lacunar infarct. This you must understand. And if that patient is drowsy, you must always look for other possible causes for drowsiness. It may be a pneumonia with low saturation. It may be pulmonary embolism, unlike sepsis. It may be electrolyte imbalances like due to SIADH causing hyponatremia, or it may be dehydration, or sometimes it may be drugs given in the ward because the patient may have been drowsy the day before. So this is a very important uh, aspect that you have to think of. You must not tell, oh sir, this patient has a small cerebral hemorrhage in the internal capsule, and this patient is drowsy due to the cerebral hemorrhage. Patients, as you all know, patients should not be drowsy unless they have a very large bilateral affection of the cerebral hemispheres or a brainstem event. Others, very small lesion, even little larger ones without midline shifts, cannot make people drowsy. Thalamus, bilateral thalamic lesions, which again are uncommon, and brain stem lesion can make the patient drowsy or sleepy. Now, this section is very important, and most of the questions come from management of stroke because now most of the hospitals give uh, thrombolytic therapy for acute strokes. As most of you would know, now in other countries uh, they advertise, they always uh, educate people regarding this fast, that is face, arm, speech, and then time. So if they have a weakness of the face, arm, and they have not mentioned leg, but speech affected suddenly, you have to call the ambulance. And if there's a possibility the patient can be transported by a safe way, you can transport them to the hospital. And that hospital, when you select, you must select a hospital with thrombolytic facilities. Uh, and right now, the ambulance team is instructed to take this patient to the closest hospital, which is better than what it was before. But we were trying to educate the ambulance drivers and to have a mechanism so that the patients will be transported, that such patients with suspected strokes will be transported directly to a tertiary care center where the thrombolytic therapy can be given. Like anything else, uh, when the instructions have there's little instructions have there are two ways of thinking. Sometimes this can be misused, and I think probably that is the concern of the managers. But somehow or other we have to go to that where the ambulance team directly identify the potential strokes and transport them to a tertiary care center. And we should not give dextrose on site unless the patient is hypoglycemic. Generally, ambulance team check capillary blood sugar and saturation. And if you want to give, if you think that the patient is dehydrated, you can give a normal saline tip. Now, triaging ETU, at the ETU, the patient should be um, prioritized as the uh, like like a patient with myocarditis. Right. Um, Now, airway breathing and circulation may be relevant in some patients with strokes who comes in a state of unconsciousness. Otherwise, do not mention ABC in all the cases, but capillary blood sugar, saturation, and ECG may be relevant. If the patient is unconscious or if the patient has breathing problem, then mention about them. Uh, After attending to the acute problems, you must always arrange a very urgent non-contrast CT brain. And that is mainly to exclude a hemorrhage. If it does not show hemorrhages and if the patient has come within 4.5 hours, then the patient is a potential candidate for thrombolytic therapy. Now there are patients who has developed the disability on awakening. When they get up, they find that there's a left-sided weakness. In those patients, we have to go back to the last seen normal. Although the patient noticed it at 6 o'clock, patient may have got up at 5 o'clock and gone to the washroom at 5 o'clock. At that time, she was normal. Then, if the patient has come by 7 o'clock to the hospital, still last seen normal was 5 a.m., still we are within the window. So you have to determine the NIH score. You will soon see the chart, and you must all, when uh, the program is opened, you can go to the ETU and find out the NIH score chart and exclude stroke mimics. I agree that sometimes it is very difficult to exclude them, but if possible, you exclude them. Otherwise, you consider them as strokes. And quickly inquire about the major contraindications for thrombotic therapy. And in this country, we always take the consent from the patient or from the caregiver. Uh, we have already mentioned that full blood count, PTINR, electrolyte and creatinine should be done, but we do not wait for the results to come. And this is the NIH score. It's a detailed one. And the importance is that if the NHS score is less than 4 or more than 25, we don't generally give thrombolytic therapy. Okay. Considering some of the contraindications for thrombolytic therapy, this again is a very important one appearing in the MCQs and the long questions. Prior cerebral hemorrhage at any time or any strokes within 3 months. Cerebral tumors, AVM or aneurysm. Active bleeding except menstrual bleeding from any side. And suspected aortic dissection, pericarditis, and allergy to TPA, alteplase, are absolute contraindications. Whereas there are certain relative contraindications, like if there's a severe hypertension more than 185 to 100 by 110, in which case we can actually try labetalol, and if we can bring down the blood pressure below these levels, below 180 and 110 by labetalol, then we can still give alteplase provided he is within the time window. Bleeding disorders, depending on the disorder, you may or may not decide on this. Similarly, anticoagulation also is a relative contraindication. Recent major surgery, recent arterial puncture in a non-compressible site, just a radial artery puncture is not a contraindication. You can always compress and stop bleeding there. Age more than 80 is a relative contraindication because in many countries now alteplase is being tried in patients above this age, depending on their pre-morbid situation. If they are pre-morbid condition is very good and he is walking about active person, then we have to try to give this benefit. Active pulmonary ulcers and active pulmonary ulcers, if they are bleeding, we are reluctant to give thrombotic therapy. And the other important thing is minimal disability. Anyway, those disabilities may improve without any treatment. If the patient is improving symptoms while you are getting ready for the thrombotic therapy, you don't give thrombotic therapy. Yes, pregnancy is a contraindication for thrombotic therapy, and checkerboard sensory pattern is that it's like your dam board, where there's sensory loss on the right side of the face and left side of the body, or the vice versa. So it's half of the face and opposite half of the body is affected. That's in lateral meningeal syndrome, right? So thrombotic therapy, and sometimes we can you go for thrombectomy. Now, for thrombolytic therapy, the patient should come before 4.5 hours, and there are no contraindications. NHS score, as I said, should be between 4 and 24, more than 4 and less than 24. Disability is not improving. If the disability is improving, we are not giving. The dose is accepted dose is 0.9 milligrams per kilogram body weight, and we give 10% of that within as a bolus. Then we monitor for the complications or improvement, and any deterioration, we have to do an urgent CT brain to exclude cerebral hemorrhage. If there is no improvement uh, with thrombotic therapy, because while we are giving thrombotic therapy, we assess their disability, the patient's disability. There is the thrombectomy that can be done. It is done to some extent at NHSL, but not very widely. It is also done in the private sector in Colombo. Earlier recommendation was that it can be done within 6 hours, but later we have found that if up to 6 hours, if there is a clinical radiological mismatch, that is, there is a very small infarct or no infarct seen in the CT scan, but uh, significant clinical disability. That means most of the disability is due to ischemic penumbra, which is amenable for revascularization. Now, subsequently, they found that if imaging can demonstrate in perfusion diffusion scans, if you can demonstrate that the penumbra is large, still there is a benefit from thrombectomy, thrombus retrieval. But if we are planning to transfer the patient to Colombo, we must contact them and ask whether they would really give this chance of thrombus retrieval for these people. Uh, Sometimes even for ischemic strokes, you may have to consider surgery. One situation is a cerebellar infarct. Cerebellar infarct, as we know, will produce hydrocephalus, and so the patient will rapidly deteriorate. And any patient with cerebral infarct, as well as cerebellar. Yes, Ireshika, what's the problem? Any problem? Right. Can you all hear me?
Yes, sir.
Right. Okay. Um, cerebellar infarcts, the patient need to be monitored carefully, and if they develop a deterioration or level of consciousness, you must do a repeat CT scan, and if there's a hydrocephalus, you have to do a shunt. Uh, Generally, first they do a ventricular drainage. Malignant middle cerebral artery infarcts are the middle cerebral artery infarcts which cause very rapid expansion due to cerebral edema and can lead to honing. And if the patient deteriorates, especially level of consciousness, and if one ipsilateral pupil start dilating, you have to quickly refer them to neurosurgeon. They will remove part of the cranium on the side of the lesion so that the further honing, further increase in the intracranial pressure will be diminished and the life can be saved. But the disability will depend on the further management of the patient. Right. We mainly discuss about the ischemic strokes all this time. And as you know, there are many causes for hemorrhagic strokes. Hypertension is again the commonest, and somebody has asked whether hemorrhagic strokes can be thrombolized. That should not be asked, because we said we only thing is if the CET excludes exclude hemorrhage only, we will give thrombotic therapy, which is very obvious anyway. In young people, you have to think of aneurysms and AVMs, and occasionally they can bleed into a tumor, and coagulopathies, especially people who are on warfarin, can have intracerebral hemorrhages, vasculitis, and sometimes cocaine abuse also can cause ICH. And this is a picture of AVM and carotid angiography of an AVM. As we discussed, ICH, one of the commonest causes is the blood pressure. So how are you going to manage blood pressure in ICH? Now, any patient with strokes, regardless of whether they have a ischemic stroke or hemorrhagic stroke, they can have hypertension as a pre-existing disease, or they also can have due to other reasons like pain, stress, and increased ICP, intracranial pressure. So you must first see whether it's really hypertension or not. This is very easy. If the patient has previous history of hypertension, then we know that this part of this hypertension is coming from his previous hypertension. But if the blood pressure is very high, as we discussed in the ischemic stroke, if it is more than 180, 110, because of the therapy as well as anyway, that has to be brought down quickly with IV labetalol. Now, with regard to ICH, also it is important to bring down the blood pressure. So, if the blood pressure is between 150 and 210 systolic blood pressure, again, now we believe that bringing down the blood pressure maybe at least will not do any harm. People have found now by research, acute lowering up to down to 140 millimeters mercury is safe, and they will not have a deterioration. If the systolic blood pressure is more than 220, you have to give intravenous infusion of labetalol and bring down the blood pressure quickly. Now, in ICH, there are clear indications for surgical intervention. Patients with a fairly large cerebral hemorrhage with deterioration of neurological functions, evidence or impending brainstem compression, hydrocephalus from ventricular. Those are clear indications. In supratentorial ICH, if the patient is deteriorating, neurologically again it may be useful, but otherwise it's not very beneficial when you compare with the non-intervention. This craniectomy, spelling mistake, but we have discussed a few minutes ago. Now, another question that the patients will ask from you is, will it recur? Now, this will be asked by the patients, both with by families of both with ICH as well as ischemic strokes. If there is a lobe location of ICH, Presence of microbeads on gradient echo MRI that we don't generally do here. Amyloid angiopathy in old age people and ongoing anticoagulation. The uh, risk of recurrence is more. Right. And in the ischemic strokes, we know that if the risk factors are poorly under control, the risk of recurrence is more. Then another question that the family would ask with a patient with a stroke is, will they recover and how long will it take? For that, there is another scale. This was not there in your lecture note. That's called Oxfordshire classification of strokes. They classify into four categories. It's total anterior territory ischemia. That is called TACI, TACI, total anterior territory cerebral ischemia. And then they have partial uh, anterior territory ischemia, posterior territory ischemia, which is called POCI, P O simple O C I, and LACI. LACI means lacunar cerebral infarct. Total anterior would be there's a dense hemiplegia on one side and may be with aphasia if it's on the right side. Partial anterior means either upper limb and the lower limb are affected with the sparing face, or face and arm is affected with sparing leg, and so forth. So those are the partial anterior. Posterior infarct, as you know, is in the posterior territory, like the brainstem. And the lacunar infarcts are very small infarcts caused by end arteries. The total anterior infarcts will have the worst prognosis in the sense that they will take a longer time to recover. And partial anterior one will be recover a little quicker, and the best prognosis is with the lacunar infarcts. Okay. Ideally, these patients should be managed in a stroke unit. And any patient with a stroke should be assessed for swallowing. And if swallowing is not possible, you have to feed them with NG feeds. Now, proper swallowing assessments are done by speech therapists, but sometimes they may not be available all the time, and you should know the correct way of assessing swallowing, which is difficult to be demonstrated in the Zoom, but we will demonstrate in the wall. You must all learn that. And if you are not sure, it's always safe. It's always uh, safe to insert an NG tube. So you have to continue risk factor modification, hypertension, diabetes, hyperlipidemia, and so forth. You must look for complications like aspiration pneumonia, urinary tract infection, bed sores, and so forth. And look after fluid, electrolytes, and nutrition, especially if the patient has problems of eating and consciousness is impaired if the patient is not taking orally. Glycemic control should be optimal. They should not go to hyperglycemia, but at the same time, hypoglycemia also should be avoided. All these patients should be referred to rehabilitation, but because of limited facilities, we select young patients and with significant disabilities who will get the maximum benefit from rehabilitation for referral. And you must look at their social and employment aspects because with regard to their employment, although sometimes the disability is minimal, their employment may not be possible. Like a teacher with acalculia, a maths teacher with acalculia cannot be employed as a maths teacher with that stroke. So similar things. A bank manager with hemianopia cannot be put as a bank manager. He will few billions, he might say, only few thousands, because he can see only one half of the document. So there are situations like that. And of course, if they have a significant motor disability, they cannot be uh, employed as manual workers. And there are some benefits that they can get. Those who cannot afford to have appliances like wheelchairs or walking sticks, there is a way to get it from the uh, social worker in the uh, divisional secretariat, and they can actually even can get funding for modification of their house and toilets also, up to 50,000 rupees. Rehabilitation should include not only physiotherapy, occupational therapy, speech therapy, and so forth. Patients with hemianopia should be rehabilitated with visual rehabilitation. Again, we'll demonstrate it when you come to the wards. Many patients will need psychological supports, but the number of psychologists we have in the country are very minimal, so that you must know to encourage them and to communicate with them, so that the patient will not be will get little better. But if they are really depressed, then of course psychiatrists should see them. Cognitive rehabilitation, we are doing it to some extent in Goa, but it is not widely practiced in this country. But many patients, like the example that I said, like patients with acalculia, can be rehabilitated so that they can now go back to their job, or they can be trained to do calculations. Especially not teachers, but those who are like shopkeepers, we can train them to use a calculator, and there are many other ways of training. Early rehabilitation will good results, and it is evidence-based that the patients managed in stroke units do better than others. And rehabilitation should be continued as community and home rehabilitation after discharge. And I have discussed about some of the social supports available. Secondary prevention of stroke. Any patient with stroke or TIA should be given antiplatelet agents, and their hypertension, high blood pressure should be controlled, and we prefer to give AC inhibitors, so ARBs, angiotensin receptor blockers, because they have shown to be beneficial in preventing uh, secondary prevention. Of course, diabetes, dyslipidemia should be stopped. Smoking should be stopped, and weight reduction is very important. And the patient should be encouraged to do normal exercises in addition to their rehabilitation exercises. Antiplatelet agents, aspirin is the favorite. Aspirin plus diphenhydramine had been used for some time, but it has gone out of uh, fashion. But clopidogrel is equally effective as aspirin. At the beginning, we give a 300 milligram dose of clopidogrel or aspirin, or sometimes both. And we continue, in most cases, we continue dual antiplatelet therapy for 3 weeks to 3 months, and then we continue with only one. And ticagrelor is becoming popular as an antiplatelet agent now. We'll skip that. Anticoagulation, on the other hand, is very important, because this will come time and again as questions. Anticoagulation is only indicated if there is a atrial fibrillation in a patient with a stroke, or sometimes if the patient has DVT. Otherwise, anticoagulation warfarin is not indicated in patient with stroke. Those with prosthetic valve and other high-risk valvular heart disease also, there is a place for anticoagulation. In patients with multiple valve collapse, and antiplatelet therapy is adequate. Then there is another part of this lecture, which I will do on Friday. I will send you the link. That's the few other issues to be discussed. One is young patient with a stroke, and as I mentioned earlier, subarachnoid hemorrhage and DVT. Any questions? Hello, Mamenang. Kiana. Kiana. Bangina. Do you have any questions? I will try to answer these. Yeah. Many questions we will answer, try to answer them. Yeah. Pregnancy is a contraindication for thrombolytic therapy. Yeah. Any somebody has asked safe blood pressure level. Yeah. Below 180 and 110. You can start it, but generally we go by 180, less than 180 systolic and 100 diastolic, but even less than 110 according to guidelines you can start it. Somebody has asked why we are giving normal saline rather than dextrose. Anyway, if the patient is dehydrated, you have to give normal saline, and if you give too much of dextrose, patient may develop. Generally these people get hyponatremia due to SIADH, and that will get worse. There is some question. Now, if you cannot bring down the blood pressure to these levels, you do not give thrombotic therapy. Now, reversible ischemia. Well, when we start treatment, that's why if the patient shows any improvement, we don't improve in disability, we don't give thrombotic therapy. But some of those patients may have anyway improved even without thrombotic therapy. But we know by pooling all these research data, we know that there's a clear benefit by thrombotic therapy. TIA, you don't need to do thrombotic therapy because, yeah, same question. Because some of those patients may be having little long duration of TIA, and that's why I said this definition of 24 hours does not hold. Similarly, now to say something is TIA, we have to wait for 24 hours. So we cannot do that, and we have no time to arrange MRIs and do other things so that the time window will be over. So some of those patients can still be TIAs, but when you pool the data, there's a clear benefit in this group of patients with ischemic strokes who were given thrombotic therapy. Yeah, I have shown you hemorrhagic and ischemic strokes. Hemorrhagic strokes will be like white, which I have shown you, like hemorrhagic, basically ICH, intracranial hemorrhage. Yeah, there is no need to give Hartmann because we want just to correct the dehydration, and the patient will be brought to the hospital. In the hospital, depending on the requirement, you can give Hartmann. There is no problem. But generally, normal saline is the accepted answer. Ischemic penumbra means the area of ischemia around the infarct, which I will try to show in the next lecture. because there is an area of ischemia which is seen in the CT, but penumbra can be seen with other different techniques like diffusion and perfusion scans. So penumbra basically means the cells are not dead. So when they are not dead, there is a potential that we can get them, back to normal. So that is why when the penumbra is large, the results of ischemia is, results of recovery is, results of treatment is better, revascularization. And we don't give tenecteplase for patients with strokes. Some centers still use it, but the results are not very good. So generally we give alteplase. But tenecteplase is much cheaper though. Yeah, more than 25, or some people say 26, we don't give thrombotic therapy because the disability is so severe, it's very unlikely that they will recover. Well, if the patient has a severe headache for 1 hour, is the onset very rapid? If the patient collapses, it could still be it could be a stroke, but it can be very likely to be ICH or subarachnoid hemorrhage, but it can be ischemic stroke also. We have seen some ischemic patients with ischemic strokes coming with severe headache and then the disability. So, okay. Did you all get something regarding strokes today?
Yes, sir.
Right. Next time, of course, the scheduled lecture is a different topic, but I will complete this lecture and there will be a few questions at the end. So, sorry, yeah. So be ready, and I might check you online or do some activity next time so that you can enjoy the participation, right? Okay. Some of the questions have been asked of me are beyond me, and I have not even tried to answer those questions. Those we have to go by the government regulations. Okay, thank you for listening. We'll have another lecture on Friday. I will send you the link at appropriate time.
Thank you,
Thank you,
sir.
sir.
Thank you, sir.
Thank you, sir.